Management of ventricular tachycardia depends on the setting in which occurs, whether it is during exercise test in the treadmill room as this one, or it is seen in the intensive care unit, operating room or emergency room. The situations vary and management also vary. Sometimes it may be recurrent ventricular tachycardia which presents with short episodes, self-limited. Then the management is different. This was a case which occurred during exercise test in the treadmill laboratory. All that was needed was stopping the exercise, and fortunately it didn't recur immediately. But similar tachycardias during exercise can occur in right ventricular outflow tract tachycardias, which are likely to recur during exercise in the usual course of time, and then that requires additional management with medication or ablation. This was non-sustained ventricular tachycardia. Ventricular tachycardia, which is lasting less than 30 seconds, is known as non-sustained ventricular tachycardia. If it lasts more than 30 seconds or requires cardioversion within 30 seconds due to hemodynamic compromise, then it is classified as sustained ventricular tachycardia. This is another situation in which ventricular tachycardia can be picked up, that is Holter monitoring. This is a 24-hour Holter monitoring which was done for evaluation of palpitation. Here, in addition to this non-sustained ventricular tachycardia, there are other interesting features. One is the QT interval appears a little prolonged. Second is that the ventricular tachycardia has occurred after a pause. Bradycardia situation is there. Heart rate is slower. We don't know the exact basal heart rate because that part has not been covered in this particular tracing. And there is also a pause following termination of tachycardia before the sinus rhythm takes over. This gives us an important hint in the management. Whenever you treat a tachycardia, be prepared for a bradycardia. That's an important dictum which you have to keep in mind in the emergency room, operating room or intensive care unit. Any tachycardia being treated, be prepared for bradycardia, and the other way around also. When you treat a bradycardia, be prepared for tachycardia. So that is usually seen. Here it is well demonstrated, that is the bradycardia as probably induced. That is something what we call as brady-induced arrhythmia. In bradycardia, the QT interval gets prolonged and there is an enhanced possibility of arrhythmia genesis. And this person has ventricular ectopy also, which is known to be a forerunner of ventricular tachycardia. And this cannot be typically called as an R on T. If it was a little more proximally, it could have been called an R on T phenomenon. Here you can see that it is definitely after the T wave. We know that ventricular tachycardia and other ventricular arrhythmias are potentially life-threatening and need more aggressive management. When you see such arrhythmia on Holter, very often it may be associated with left ventricular dysfunction. So when ventricular tachycardia is associated with left ventricular dysfunction, management is different. Some drugs which can be given for those without left ventricular dysfunction like flecainate cannot be given. And such patients often end up with a defibrillator, and the cause of left ventricular dysfunction also has to be managed. Depending on the morphology seen in ECG, ventricular tachycardia can be divided into monomorphic. This is monomorphic. Almost all beats have similar morphology in a given lead. Between leads, there can be variation, and that is known as monomorphic ventricular tachycardia. Ventricular tachycardia by definition is 3 or more beats of ventricular origin occurring in rapid succession. That means at a rate more than 100 per minute. If it's only exactly 3, sometimes it is also called salvo. the shortest form of non-sustained ventricular tachycardia. This is a sustained ventricular tachycardia of monomorphic variety picked up on ICU monitor. This is an ICU monitor screenshot. Such arrhythmias are often managed with amiodarone, bolus followed by an infusion. But occasionally, when it is due to ischemia, acute ischemia, they can also be managed by intravenous lignocaine. Earlier, when we were students, amiodarone was not the sheet anchor in the ICU, it was lignocaine, bolus followed by infusion. But use of lignocaine has come down, and now mostly it is amiodarone which is used for monomorphic ventricular tachycardia as initial management. Though amiodarone is a slow-acting drug, very often in the ICU we find that there is effect with intravenous amiodarone. There are also other medications like procainamide and sotalol which we seldom use in this region, mainly because of lack of availability and other concerns. Very often in an emergency we end up with a direct current shock, defibrillator shock for management of a monomorphic ventricular tachycardia with hemodynamic compromise. By hemodynamic compromise, we mean hypotension, angina, or heart failure. Those are the situations in which immediate direct current shock is given. And when the shock is given, usual precautions have to be followed. That is all clear. Nobody is touching the person to avoid shocks. Then area should be prepared well so that jelly contact with the chest is good. Thoracic impedance is not high. The paddles are pressed on the chest to avoid skin burns. Those precautions are of course needed. After the shock, in case there is bradycardia, you may have to manage that. If there is no bradycardia, most often it takes up in sinus rhythm like this. It has gone into sinus rhythm. Even though the ECG is not very clear, it is narrow QRS. There is in fact mild tachycardia after recovery from ventricular tachycardia. Initial phase, there could be bradycardia because heart may take some time to recover. That's why a pause can occur after the DC shock. This is an important, potentially life-threatening polymorphic ventricular tachycardia. Compare the beats. Each beat is having a different morphology. It is known as toss at the point. This term means twisting of points. That is, if you take an ECG like this and twist it, ECG with a monomorphic tachycardia, and you try to twist it like this, the pattern will appear like this. That is, it goes on increasing in amplitude and then decreases, then again increases. So polymorphic ventricular tachycardia. That is associated with QT interval prolongation. This is QT interval prolongation in an ECG after recovery from this. They are known to be self-limited, short episodes, but occasionally it can be prolonged and may require electrical cardioversion. But most often they are short episodes, not requiring cardioversion, and you need medical management for that. So this is, you have to check the ECG during intervening period will show QT interval prolongation. Here there is also a giant T inversion. It is most likely that this person has had a cardiac arrest. Ischemia is one important setting in which this can occur. Then there are other conditions like cardiac channelopathies, Brugada syndrome, long QT syndrome, all can predispose. Another important cause is electrolyte imbalance. Hypokalemia and associated hypomagnesemia can cause this type of polymorphic ventricular tachycardia. So you have to look at all these factors. An ECG when there is no tachycardia is very important. That's important in all cases. In other cases, you may detect other abnormalities. For example, the person may present with monomorphic tachycardia, and when you take the ECG after that, you may see old infarction. So it could be a scar-related ventricular tachycardia. And in this case, you may see a new infarction because polymorphic tachycardia usually is in the setting of acute ischemia rather than a reentrant tachycardia of a scar. Polymorphic ventricular tachycardia with QT interval prolongation is often managed with intravenous magnesium sulfate. This is highly effective, very cheap drug. It is given as an initial bolus infusion followed by a more longer infusion to correct abnormalities in electrolytes. It immediately treats polymorphic ventricular tachycardia with QT interval prolongation, and it also corrects magnesium deficiency, which is often associated, and hypokalemia correction also is better. Once you check the electrolytes, if you get the potassium value as low, hypokalemia correction also has to be given along with it. Magnesium levels can also be checked, but there is a slight drawback that magnesium is mostly an intracellular electrolyte, so the values may not be so much supportive of our management, but we can check magnesium levels as well as potassium levels in any case of polymorphic ventricular tachycardia. In any arrhythmia, we'll check electrolytes. This is a different type of polymorphic ventricular tachycardia known as bidirectional ventricular tachycardia. One beat is in one direction, another beat is in another direction. This is bidirectional VT. Actually, this is not a full ECG. I have just added beats together because the tracing showed, this was a Holter tracing, showed only one set of bidirectional beats, and this is a computer synthesized rhythm to demonstrate bidirectional ventricular tachycardia. There are three conditions in which bidirectional tachycardia occur. One is catecholaminergic polymorphic ventricular tachycardia. It's a cardiac channelopathy. It can have exercise-induced arrhythmias in children, CPVT. Second is Anderson-Tawil syndrome. That's a type of long QT interval syndrome. Congenital long QT syndrome can also have bidirectional ventricular tachycardia. The third is classical arrhythmia in digoxin toxicity. Bidirectional ventricular tachycardia is a classical arrhythmia of digoxin toxicity, but we seldom see that these days as the use of digoxin has come down. In conditions like cardiac channelopathy, this will require different management. There are specific varieties of monomorphic ventricular tachycardias known as fascicular ventricular tachycardia. It can be posterior fascicular tachycardia, anterior fascicular tachycardia, or even rarely septal fascicular tachycardia. This is one of the ECGs which we had published in Indian Pacing and Electrophysiology Journal. It is showing right bundle branch block pattern. You can see V1 RBBB pattern, and there is left axis deviation RS pattern in inferior leads. So that is RBBB left axis deviation pattern suggestive of posterior fascicular tachycardia. It's the commonest of the fascicular tachycardia. The importance is that this tachycardia has a relatively narrower QRS compared to usual ventricular tachycardia, and just like supraventricular tachycardia, this tachycardia is responsive to verapamil. So these are verapamil responsive tachycardia, but they are recurrent, and you can manage it by catheter ablation. Radio frequency catheter ablation is an important method of long-term management of fascicular ventricular tachycardias. This is a diagrammatic representation of posterior fascicular tachycardia reentrance circuit. That is posterior fascicular reentrance circuit. Here it is AV node is bundle, right bundle branch, and the anterior fascicle of the left bundle branch. These two are fascicles of the left bundle branch. Occasionally there could be also septal fascicle, which is not shown in this diagram. So ablation will be in this region to remove the tachycardia. Whenever there is recurrent ventricular tachycardia which is not amenable to medical therapy, you need implantation of a cardioverter defibrillator, usually implanted in the left pectoral region subcutaneously, and the leads are taken through a subclavian venous puncture into the heart. The leads are shown here. This is this lead having high voltage coil in the superior vena cava. There is another high voltage coil in the right ventricle, and high voltage coils are thicker, and this device can detect arrhythmia and give shocks when needed. It can also do overdrive pacing for ventricular tachycardia, but if overdrive pacing fails, or if it's a very fast tachycardia which can produce hemodynamic compromise, immediate cardioversion is given. The cardioversion joule level will be lesser because it is given internally. And as I mentioned initially, whenever tachycardia is treated, you need backup pacing there. These are tip electrodes here, 2 electrodes which are for backup pacing if there is post-shock bradycardia. I am very fond of showing this ECG whenever I discuss ventricular tachycardia. This is an ECG showing RBBB pattern and ST elevation with T inversion in V1, V2 and V3. This is Brugada syndrome. Brugada syndrome was described by 3 Brugada brothers in 1992. That is Joseph Brugada, Pedro Brugada and Ramon Brugada. So I am happy because this was sent to me directly by Professor Joseph Brugada for the inaugural issue of Indian Pacing and Electrophysiology Journal. You can see the date here, October, and the issue number 11. This was the review article by Professor Brugada and his brothers, published in Indian Pacing and Electrophysiology Journal. That is a nostalgic memory for me. This article was very important for the journal as it increased the readership significantly right from the first issue, as Brugada syndrome article by Brugada brothers is very important for us. So that is Brugada syndrome. It is prone for life-threatening ventricular arrhythmias that can be managed by quinidine to some extent in those who are not tolerating a defibrillator, but the sheet anchor of treatment for Brugada syndrome with arrhythmia is implantation of a cardioverter defibrillator. QT interval prolongation was discussed initially in the setting of polymorphic ventricular tachycardia. Common causes are electrolyte abnormalities like hypokalemia, hypomagnesemia, and drug-induced. Drug-induced QT prolongation is very important. There are several drugs which can cause QT prolongation, and QT testing is now mandatory, legal requirement before any new drug is launched. So that's a very great industry also, because there are so many ECG laboratories dedicated for checking QT interval for any new drugs which are introduced or planned to be introduced. This discussion is not on that. QT interval prolongation can occur congenitally as congenital long QT syndrome, genetically determined. There are several genotypes, LQT 1, 2, 3, it goes on like that. Newer varieties are being described and different genes are also being described, and most of them eventually need a defibrillator because that is probably the safe option. There are other options which I will come to. Beta blockers are the most important medical therapy of congenital long QT syndrome, especially in children. Children, they are frightened by shocks of defibrillators. Adults are also frightened, and many do not appreciate the shock, except that you can counsel them saying that it is a life-saving device. They might accept. But there are people who do not accept defibrillators in adults as well. So in children, beta blockers are a must in long QT syndrome, except in one variety, that is long QT3, which is a sodium channel related long QT3, and it is also bradycardia related. So you will not give beta blocker for long QT3. Mexiletine has been tried that's a lignocaine-like drug. People will also call it as oral lignocaine, has been tried in LQT3 variety. All other varieties require beta blockers. And lipid-soluble beta blockers are better. And propranolol may have an advantage because it has additional local anesthetic-like or membrane stabilizing effect. There are some studies showing advantage for propranolol, but here the image has been just put as a representative image. Some use longer acting drugs like nadolol, but we don't have access to that drug in this region, or at least I have not seen that. So beta blockers are most important medical therapy for congenital long QT syndrome. So finally we conclude by saying that management of ventricular tachycardia is highly individualized depending on the cause and other situations which cause the ventricular tachycardia.